And then if you just want to share your screen, then you don't have to worry about you being on it. This one? Presentation?
Yeah, maybe just do the screen. That'll.
It should be this one. Okay. This, yep. And then I can turn down the lights or whatever you want. If you think it's too bright, you let me know. I use your AV. Okay. Yeah, it's the same account. So the account itself is this, and then it has all the different.
Oh, okay. I listened to
So you can hit subscribe if you have a YouTube. I won't do it for you, but you can subscribe, and then it'll always come up.
So now, this is the one I listened to. This here. So now, is this our second one?
No, they're all different. Like these are even the videos from the ones from the last session.
Oh, okay,
So you can catch up on anything.
and these all belong to you. Yeah, I did listen to one and I said, this is somebody else on here. I said, very interesting.
Yeah, nope, it's all still through the same program. Yeah. So like the last, the first round we did it, we had a couple speakers that were slightly different than the speakers we had this one. So I wanted all of it to be accessible.
Oh, perfect. I'm so glad that's part of
Oh, so you have the last.
Wonderful.
Yep, are on there too.
Okay. Thank you. Thanks.
So like we weren't lucky enough to have Krissy the first round, but we have her this time. So you guys get to be the first ones to get PharmD, but then I provide the links to everybody who's participated in the entire program from start to finish, so they can go back and even hear what she has to say. So, and of that I know of, they have been so looking on stuff and everything. So.
Okay, cool. All right, well, I can go ahead and get started then. So my name is Krissy Keaton. I am the rheumatology pharmacist at our main campus rheumatology clinic. So I work with the doctors, nurse practitioners, physician assistants in the rheumatology clinic and assist with managing and monitoring medications for a variety of conditions, a lot of different inflammatory arthritis conditions, as well as osteoarthritis. So today I'll be talking to you guys about managing medications for arthritis. No, I'm down at main campus. Yep. So today we're going to be discussing over-the-counter medication options for the treatment of osteoarthritis, identifying other prescription medication options for treatment of osteoarthritis, and then we'll just describe some general tips for managing medications. So most of what I'm talking about today is for treatment of osteoarthritis. However, rheumatoid arthritis or other inflammatory arthritis symptom management is generally the same. So we can also apply these tips to rheumatoid arthritis and other forms as well. So just to start, as you all probably already know, osteoarthritis is our most common form of arthritis, affecting over 300 million people worldwide, and it's caused by the breakdown of the joint cartilage between your bones. So picture there depicting a normal joint space on the left, and then breakdown of that cartilage space, which can cause the bones to rub together and cause pain. So in comparison to rheumatoid arthritis, that is an inflammatory arthritis that is due to our immune system not functioning correctly. So the immune system will attack the joints and cause inflammation in the synovium, that fluid space between the joints. So both of them we're treating to help relieve pain, but we also have medications for rheumatoid arthritis that we know can also modify the progression of the disease and prevent further damage to the joint. We're not quite there yet for osteoarthritis, but we have medications that can at least help with symptoms. And then some other major differences between the two types. So osteoarthritis typically is worse when you're active and moving your joints too much, like overusing, although we do want you to still be active with osteoarthritis. But then patients with rheumatoid arthritis typically feel better with joint movement and like stretching out those joints. Usually osteoarthritis, we see involvement in kind of the bigger joints, so knees, hips, spine, hands, maybe like at the base of your thumb, whereas rheumatoid arthritis is usually symmetrical on like both sides of the body and usually the smaller joints, so fingers, toes, wrists. And then we usually see more morning stiffness with with rheumatoid arthritis, sorry. So when patients wake up in the morning, they're usually feeling pretty stiff. Takes a while to loosen out those joints, whereas with osteoarthritis, usually with rest, your joints will feel a little bit better. Yeah, good question. So there's different lab tests we can use. So we can monitor for inflammation markers that will usually be elevated when patients have rheumatoid arthritis. There's also certain like antibodies that we can measure. So if those are positive, that leads us towards rheumatoid arthritis. And then usually just looking at the difference in symptoms. So is your pain the worst when you first get up, or is it worse throughout the day, later in the day? Do you wake up with stiffness or do you not? Where are the joints? Is it both sides of the body? Yeah.
Can you have both?
Yeah. Yeah. No, you can absolutely have both. We have a lot of patients that do have both. But rheumatoid arthritis ultimately will be diagnosed through, there's like a checklist of symptoms and labs presentation that like you get points based off of the number of joints involved, which joints are involved, what labs are positive, the onset of symptoms, things like that. So there's a whole criteria. Usually, I mean, primary care providers can order them, but usually ultimately a rheumatologist is going to be the one that's like diagnosing and treating. Yep. So right here, then, this is taken from the osteoarthritis guidelines, basically recommendations for management, both non-pharmacologic and pharmacologic. So it's important to note that there's a lot of different things that aren't drug related that you can do to help with arthritis, whether that be exercise, weight loss, tai chi, acupuncture, yoga. So lots of different activities that you can consider to help with joint pain. Whereas today we'll be focusing more on the medication options, both over-the-counter options and then options that need to be prescribed by a physician. So today we'll be discussing topical, oral, and injectable options for osteoarthritis. So some examples for that would be topical would be our topical NSAIDs. So NSAIDs are non-steroidal anti-inflammatory drugs, topical capsaicin, and then oral options, NSAIDs, acetaminophen or Tylenol, duloxetine or Cymbalta, chondroitin, tramadol, and then for injections, injecting steroids into the joint. The ones that we'll be focusing on first here are going to be ones that you can get over the counter on your own and take. So that would be our topical NSAIDs and capsaicin, and then oral NSAIDs, Tylenol, and chondroitin.
So Tylenol is better than that.
We'll get into that. So starting out with our topical options. So these are either creams or gels that you would be applying to the specific joint that's involved. Typically, these will have less systemic exposure. So since they're not absorbed into the bloodstream and going throughout your body, will have fewer side effects compared to our oral NSAIDs. When we look at the arthritis guidelines, these topical NSAIDs are strongly recommended for the knee joint. You can consider using it on your hands as well, but typically the topical options aren't recommended for your hip just because the joint is further in under the skin and fat, so it can be harder for a topical option to really reach and be effective in the hip joint. So the best, or really the option that we have as far as topical NSAIDs go, is diclofenac or Voltaren gel. So this gel was originally only available by prescription. It's now available over the counter. So you can purchase it yourself over the counter, or a doctor can prescribe it. You can see if it'll go through your insurance. But these medications are dosed based off of the joint that you're using it on. So if you're using it on a bigger joint, such as your knee, you're going to use a larger quantity. So 4 grams to that area up to 4 times a day. Whereas if you're doing it on your hand, smaller joints, it would be 2 grams to that joint up to 4 times a day. And there's maximum recommended amounts that you'll give yourself in each joint, and then total 32 grams for all of your joints in one day. The way you measure this is they actually give you a dosing card in the packaging. So it's not like you're going to be weighing out 2 grams. They just have a strip there where you'll squeeze out a strip of the medication that's about equal to 2 grams versus 4 grams, depending on how long of a strip you squeeze out, and then you'll rub that in thoroughly to the joint area. Okay, yeah. So this one, so I mean, it's a great option. The thing is that patients, I think, typically will sometimes like apply it once and then be like, oh, I don't think that worked. But you really do need to do like the 4 times a day, stick with it for, I'd say probably at least a week before you completely count it out. But just some tips then when using these types of topical medications. So always applying it to clean skin, avoiding anywhere that you have an open wound, avoiding your eyes. You don't want to cover it afterwards with a bandage. You want to keep it open. And you also, yeah, well, technically they recommend not putting clothes on for like 10 minutes or so afterwards. So you want to give it time to fully absorb in before you're covering it up or potentially wiping it off by putting on clothes. You also don't want to shower or bathe for an hour afterwards. You want to wash your hands immediately after applying, but if the area you're applying is your hands, you want to wait at least a half hour. But otherwise, wash your hands. And then, like I said, avoid clothes and avoid direct sunlight to that area. So any questions on Voltaren before I move on to the next? Okay, so next topical option that we have is capsaicin. So this one is actually derived or made from hot peppers. And it's best to use really when only we have one or just a few smaller joints involved. So knee could be good. You can consider using your hands. The problem with your hands though is you risk touching your eyes and then causing a burning sensation in your eyes. Again, not recommended for the hip because that's going to be too far deep in the joint to really get effect from it. This one is also available over the counter. You can get it as a topical cream, gel, or lotion. It also comes in a patch form, which is usually like those salon pass patches. Tips for this one, so you want to gently rub a thin film into the area so they don't give exact recommendations like a card for the amount. But again, you'll use it 3 to 4 times a day. You want to either, if you're not applying to your hands, use gloves or wash your hands immediately after, because like I said, it can burn if you touch your eyes or another mucous membrane. And then if you do apply your hands, again, you want to wait 30 minutes before washing it off. The patch then you can apply for up to 4 hours, or sorry, up to 8 hours with a maximum of 4 patches per day. But they do say not to use for more than 5 consecutive days. So you can use it for a couple days, maybe take a break and then use again. No, Voltaren you can keep using. Yep. So basically similar tips as with the Voltaren. You want to still apply it to clean skin, avoid damaged skin. Also avoid applying it in skin folds because that could then like occlude the medication and make it be more absorbed. You don't want to cover it with bandages. You also don't want to use this capsaicin, so a little bit differently. Don't want to use it an hour before or after a shower or combining it with any heat, because that could then cause further absorption beyond just the topical space that you're applying it to. So a little bit more specific as far as applying the capsaicin and avoiding heat sources, avoiding bathing. And then they don't recommend using capsaicin along with another topical analgesic. So I would use Voltaren and capsaicin, picking one or the other. So those are our two topical options that you can get over the counter for pain. From there, though, recommendations would be for our oral options. So oral NSAIDs or non-steroidal anti-inflammatory drugs are basically our mainstay of treatment for osteoarthritis. In our guidelines, they're given strong recommendations for all of the major sites, so knee, hip, and hands, and recommended to be an initial medication of choice. However, there are some conditions where oral NSAIDs may not be the safest option for patients. So one being if you have strong cardiac history, so either history of a heart attack or stroke, if you have high blood pressure or you have heart failure, because it's known that NSAIDs can potentially worsen blood pressure or can put you at risk for cardiac events. Otherwise, also, if you have history of a gastrointestinal bleed or an ulcer, NSAIDs can worsen that. And they are also not the best options for patients with kidney disease or liver disease. So all of these conditions, you definitely want to run an NSAID by your doctor first before deciding to start on your own. So examples of NSAIDs that can be used. So the top two are ones that are available over the counter or by a prescription. So ibuprofen, which is also known as Advil or Motrin, and then naproxen, which is also known as Aleve. Those two you can get over the counter at a lower dose, or you can get a prescription that comes in a higher dose. The ones all at the bottom of this chart are ones that require a prescription. So typically the ones that you'll see prescription or given via prescription are often the celecoxib or Celebrex and then meloxicam or Mobic, mainly because those two are dosed less frequently. So Celebrex can be given once or twice a day. Meloxicam is only a once daily medication. So there are ideal options to not have to take frequent doses of an NSAID, whereas our over-the-counter options, you need to use at least twice daily, maybe up to 4 to 6 times a day. So just diving into those two over-the-counter options a little bit further. So ibuprofen over-the-counter comes in a 200 milligram dose, and you can take 1 to 2 tablets every 4 to 6 hours as needed. Recommended, though, a maximum of six tablets per day if you're just taking it on your own without any guidance from a doctor. The prescription strength option, though, comes in higher strength, so up to 800 milligrams. You can take that either every 4 to 6 hours at a lower dose or every 6 to 8 hours at a higher dose. And you can take higher amounts per day. So max 3,200 milligrams per day if you're taking it under the guidance of a physician or a nurse practitioner and physician assistant. So those are our options for ibuprofen. Really, you can take the over-the-counter form and take 4 tablets to get to the 800 milligrams. There's no difference in getting that 800 milligram versus taking more of the 200. But I wouldn't take that high of a dose unless you're talking to a doctor. Aleve is our other NSAID that you can get over the counter. So that one comes in a 220 milligram tablet. You can take 1 tablet or capsule every 8 to 12 hours as needed, and usually a max of 3 per day, whereas the prescription strength comes in higher strength, so up to 500 milligram, and usually it's dosed every 12 hours, so it can be taken less frequently than ibuprofen. Maximum of 1,000 milligrams per day if you're getting it through a prescription, so usually that will be like 500 twice a day. So any questions on NSAIDs before I move on to Tylenol? Yeah, go ahead.
In general, what is considered the least harmful to kidneys with long-term use?
So kidney-wise, there isn't really one that I would say is least harmful. There's some of the prescription options are less harmful cardiac wise, and then some are less harmful, like for the GI system. So that's where things differ. Over the counter though, as far as kidneys go, there isn't really one that I would say is necessarily safer. Ultimately just taking the lowest amount for a lowest period of time would be the safest option. But typically if you're going to be on NSAIDs, like for an extended period of time or taking them regularly, definitely want to let your doctor know so they can monitor your labs just to see if we're seeing a bump in that creatinine level, which is what we use to measure kidney function.
I was gonna, ask, I think I can remember at one point being told to try to switch over to a lead because Advil was harder on kidneys. Was stomach. Advil was harder on your stomach than the Aleve.
Potentially, I mean, they're both considered to be like, they're not selective for a certain receptor that's that NSAIDs are targeting. So both can be a little bit harsher. Some of our prescription options like Celebrex might be a little bit better on the stomach. If you're going to be taking them long term, potentially your doctor might recommend taking like an acid reducer, like a PPI, like Prilosec along with it. So that's an option if you're taking it long term to help protect the stomach. So if you have issues, GI issues at baseline, you might avoid NSAIDs altogether, but we might be able to take it along with a PPI to help protect the stomach. Yeah. Mm-hmm. Okay, so Tylenol is our next option. So typically we reserve Tylenol more for patients that are unable to take the oral NSAIDs, just because Tylenol isn't usually seen to be as effective as our NSAID options. It might be something that you could try. Tylenol along with like Voltaren gel might give you more efficacy, but typically Tylenol on its own isn't the most effective option. And then we want to monitor while patients are on Tylenol, especially if you're taking it at like max dose for a regular period, making sure that we're looking at your liver enzymes, because Tylenol is broken down through the liver and can potentially cause some harmful effects to the liver if taken at high doses for a long period. So Tylenol can be a little confusing because we've got a couple different options that you can buy over the counter. So we have the regular strength, the extra strength, and then the arthritis strength. So typically, I mean, you can tell which one's which. They will pretty clearly label on there. But usually the regular strength is the white box, the red box is extra strength, and then that one with the yellow on it is arthritis strength. Difference here is that they're going to be different strength of tablets. So regulars are lowest strength at 325, extra strength is 500 milligrams, whereas arthritis is 650 milligrams. And then also how the medication is released in your body. So regular and extra strength are immediate release, whereas the arthritis strength is going to be an extended release, so it lasts longer. How that helps is that the arthritis strength you have to take, or you can take less frequently. So lasts for up to 8 hours. So you can take it every 8 hours, whereas our regular and extra strength are more frequent dosing, so every 4 to 6 hours. Each of them you can take up to 2 tablets at a time, and then just follow the recommended frequency based off of the type you use. And then the maximum amount for each varies slightly, but it's usually around 3 to 4 grams. So important to know when you're looking at the different Tylenol options that some will be longer lasting, some you have to take more frequently. So kind of pick what you think is best for you. A lot of times for arthritis pain, the arthritis option is best because it gives you longer acting benefits, and you have to take it fewer times per day. Okay, so our next medication option is chondroitin. So this is an over-the-counter supplement that you often see combined with glucosamine. We actually don't really have a lot of evidence for glucosamine being super effective though. So chondroitin is usually of the two, the one that we have more evidence for. It's typically though considered more for like our smaller joint involvements for the hand, because we don't have a lot of evidence of it being super effective for the knee or the hip. So if you're going to use chondroitin, it's best if you typically have more just hand involvement for osteoarthritis and not for hip or knee. And then there's no need to get the combination product because we don't see any extra benefit from the glucosamine. So just to echo that, then medications that are included in the guidelines that don't have efficacy, there's more, but these are some of the main ones that I get asked about. So glucosamine, and then fish oil, while it's effective for other things, so cardiovascular benefits, cholesterol benefits, it hasn't been shown to be effective for joint pain for osteoarthritis. Nope, typically will just be glucosamine. Yep.
Glucosamine help any other body part? Why do they always put those two together?
I mean, I think for a while it was thought that the combination was effective, but since more studies have come out, they've really seen that the glucosamine component really is not any more effective than just placebo.
No, usually it was often.
Yeah, glucosamine chondroitin, it's usually like the osteobiflex or chondroitin.
Right.
It,
Right.
yeah, not to say that glucosamine is going to be harmful, but really the combination doesn't seem to add any more benefit.
Do you have any revenue of fish, like shellfish or?
Yeah. Mm-hmm.
Like, I'm allergic to shrimp and then we're all. No.
Yeah, there's
And that's
the chondroitin. Yep. Yeah, typically we do avoid it for patients that have shellfish allergies, just to be on the safe side. But one thing to point out, if you are taking over-the-counter dietary supplements, so vitamins, minerals, herbal supplements, typically, well, these medications, they're not as well regulated by the FDA, so they don't have to go through as rigorous safety or efficacy approvals as our prescription drugs do. However, there is a group called USP that will do like outside verifications of supplements, like testing for ingredients to make sure that it matches what's listed on the bottle, testing for potency, strength. So if you are buying a dietary supplement, ones that have this USP verified on the label is usually a safer choice options. Typically everything that you'll see at the drugstore, like the Nature Made or like the big brands, are going to have this USP verification on it. If you're ordering online, you can usually see that label on like when you're ordering. So that's just another thing to look out for when using over-the-counter supplements, just to give you a little bit more peace of mind that it has gone through some extra testing and regulation to make sure that what it says it is what's in the tablet or capsule. Yeah.
So, if you're having issues and you would want something to help you alleviate the pain right now, you go with the things that you first spoke of.
Yeah.
And then now, so you get yourself somewhat comfortable, then would it be to start on a chondroitin type of as a maintenance rather than, would you notice less pain than possibly by doing the chondroitin?
Yeah, you can potentially add on the chondroitin for less pain. I will say, yeah, by itself, you probably won't see as much efficacy as with the NSAIDs or with Tylenol, but it could be an add-on to maybe allow you to use less of the NSAIDs, so less damage potentially to the kidneys or cardiovascular risks. So that's probably where I would consider it.
It'd be more like a maintenance versus the other one is an acute.
Yeah, the other ones, they are cute if you're using like the prescription strength of them. A lot of times those will end up being a scheduled daily drug. But yeah, for the over-the-counter options, I mean, some patients take those scheduled. The naproxen, potentially like the twice-a-day ones might just kind of end up being a scheduled medication. But yeah, the chondroitin can help you to use the as-needed NSAIDs less frequently, potentially.
And are there any vitamins, minerals, or groups that you should avoid?
No, nothing really that makes it worse. The chondroitin is really the only one that was included in the guidelines as something that has like more rigorous studies to show efficacy. So yeah, nothing that I would really say absolutely no, don't take. My typical thoughts on supplements is a lot of them aren't as strongly studied or regulated. So as long as they're not harmful, I think they're fine to try and see if you find benefit from it. Yeah. So those will both be good for your bones. Vitamin D, yeah. No, won't hurt. Vitamin D was included in the osteoporosis guidelines as just an option that was not seen to be beneficial, not going to be harmful, but won't be something that will help. Yeah, again, good for the bones, but won't provide benefit for osteoarthritis. Yeah, absolutely. So just kind of a summary of what I discussed so far. So typically our oral NSAIDs are going to be the most effective option for all of our joints, but you can consider topical NSAIDs, especially for the hand and knee, and then capsaicin mostly for the hand, but mostly for the knee, but could consider the hand, but never using those topicals on your hips because they won't be very effective. And then chondroitin, mostly consider for the hand, not a lot of benefit for those larger joints. And then glucosamine and fish oil really have not seen benefit for any of the joints. So then there's a couple more options that I just wanted to touch on briefly that are options that are prescription only that can be considered for osteoarthritis. So these would be duloxetine, tramadol, and then corticosteroid injections. So duloxetine brand name is Cymbalta. It's a medication that's indicated for patients with moderate to severe osteoarthritis and have not responded well to oral NSAIDs, or you can't take oral NSAIDs due to like cardiac reasons or GI reasons. So duloxetine was studied mainly for use in the knees, but can be considered for hands and hips. And it's also a medication that's indicated for anxiety, depression, neuropathy, fibromyalgia. So it can sometimes be prescribed as a medication that kind of kills two birds with one stone because it can be effective for more than one condition. It's a once daily medication that you typically start at a lower dose and then increase up to a higher dose. But it is a medication that's not recommended to be stopped abruptly, especially if you've been on it for like at least a couple of weeks. You'll want to taper down on it. And then there can be increased efficacy with that higher dose, but also comes with more side effects. So most commonly what we see with Cymbalta is potentially some fatigue, a headache, nausea, constipation, insomnia. So can come with more side effects than our NSAIDs, but can be an effective option. So typically we want to try the NSAIDs first, and then Cymbalta could be considered. Again, prescription only though. Tramadol is one of our more last line options because this is an opioid medication. So it is recommended to be considered for the hand, knee, or hip per the osteoarthritis guidelines, but they only saw a very modest benefit for long-term use, so a couple months to a year. So really only considering this if we have no other options. NSAIDs aren't an option just because it does put you at risk of dependence or addiction because it is an opioid medication. But for completeness sake, this is an option that can be considered. This one you would take usually every 4 to 6 hours, can be more of an as needed medication. Another one you don't want to stop suddenly, you have to taper. And then has opioid side effects. So constipation is a big one, but then can also see some nausea, dizziness, drowsiness. So again, something that we're reserving for patients that try and fail other options. And then corticosteroid injections is our final option. These are strongly recommended for our bigger joints. So for knee or for hip, we have a little bit less evidence of their efficacy for the hands. And then typically these can be given as often as like every 3 to 4 months. So if you see an orthopedic doctor or a rheumatologist, they're typically who would be giving these injections. So it's something to consider, help kind of provide a cushion and provide relief, anti-inflammatory relief directly to the joint. So then I wanted to just take a couple minutes just to give some of my like general medication management tips. So just want to dive into a little bit regarding like storage, remembering to take medications, those types of things. So big thing with storage is keeping all medications in a cool, dry place. So I know a lot of people keep medications in their bathroom. That is not the best place to keep your medications because of the temperature fluctuation and the humidity in the bathroom. So best examples would potentially be like in your kitchen or a nightstand, somewhere where the temperature stays more consistent, keeping out of reach of children, and then trying to keep medications in their original bottles so that you know the expiration date on them and you're not like mixing medications within a bottle. Yeah, so pill boxes are great. Is that what you meant?
Yeah, saying not to mix them, but
Yeah, so if you're mixing them in there, that's fine. I've had patients in the past that will just take like all of their medications and pour all the bottles into one bottle. And they're like, well, I know the green one's this drug. I don't love that idea. So yes, pill boxes are great if you hang on to the original bottle as well, just so then you're very easily able to identify what bottle you took it from, what the directions are, when it expires, those types of things. So yeah, recommend it here as an option for remembering to take your medications. Other options could be setting a timer on your phone. There's some different apps you can download. You can make a schedule on a calendar or make a chart that you check off. And then just wanted to talk briefly about drug interactions with some of the medications that we talked about. So big things with oral NSAIDs is that you want to avoid them if you're on any sort of blood thinner, because we can potentially see increased bleeding risk if you're on warfarin, Eliquis, Xarelto, Pradaxa, if you're combining those with oral NSAIDs, especially if you're taking them at a regular scheduled interval. Some of our blood pressure medications, especially the loop diuretics, so typically Lasix, Umex are the common ones for that. It can be harmful to the kidney if we're using both of those at the same time. So typically not the best option. And usually patients on those medications, it's often used for heart failure, which NSAIDs are not a great option for either. And then methotrexate, I get this question a lot in rheumatology. It's a medication we use very commonly for rheumatoid arthritis. Generally, it's okay to take NSAIDs along with methotrexate at doses used for rheumatoid arthritis because it's such a low dose. But if you have impaired kidney function, or if you're taking higher doses for another indication, then you would definitely want to talk to your doctor first. And then Tylenol, really not many drug interactions, but probenecid is a medication we use for gout that can increase the amount of Tylenol in your body, which could then lead to further issues with the liver. And then also using Tylenol along with excess amounts of alcohol can be rough on the liver as well. And then finally, just another blurb about herbal medications, especially in regards to drug interactions. Just because it's made of natural ingredients does not mean that it's free from drug interactions. So typically say to check with your pharmacist before starting any new herbal medications. I typically look at like a natural medicines database where I can test for drug interactions with an herbal supplement and prescription drugs. So definitely something that you can ask at the pharmacy or ask at your doctor's office if they can double check before starting a supplement. And then, oh, I have one more slide here about medication disposal, which is often a question that I get asked as well. Some pharmacies will have drop boxes. I know a lot of our Cleveland Clinic pharmacies have an option where you can dispose of medications. You can do a Google search for like FDA drug take back locations, and there's actually, you can put in your location and they'll tell you spots near you. And then oftentimes there's like national drug take back days, which I think just happened like last week. Last resort though, if you do need to dispose of medications on your own, basically trying to like crush them and mix them with something undesirable. So like coffee grounds, kitty litter, food scraps, and then putting them in some sort of sealed container and in the trash from there. That makes them undesirable to any animals or if a person would get into your trash. So just some tips on that. Oh, I guess slide again. One more slide on just general tips of keeping a list of your medications, taking them with you, just so if you were to go see a new doctor, end up in the emergency room, anything where they may not know what meds you're taking. Ideally, if you're filling medications, trying to fill them all at the same pharmacy so that they know if there's any interacting drugs. And then also never stopping or starting a medication without talking to your doctor first, unless it's something that you know you were told to take like as needed for a certain period of time. And with that, I will take any additional questions that you guys have.
What's your take on gel injections?
Yeah, so it's definitely an option. I think the guidelines recommend steroid injections over gel injections. I don't deal with them as much in my role, but I know they do a lot of them in the rheumatology office. So it's definitely something that can be considered.
They started, I have osteoarthritis of the knee that's moderate.
Mhm.
And they started with some cortisone.
Yep.
And then they started to say, we can't do that long because that can actually also
Yeah.
wear down.
Yeah.
Cartilage, which is already.
Mhm.
And then, I'm back at Cleveland Clinic. And I started using the flex.
Yep. Yep.
So I've done that. And then I'm just kind of like at the end of my options now, so it's like for 10 years.
Yeah. Yeah.
And it was helpful when they said it would come wax, like remain, like it would be
Mhm.
less effective the first couple times you do it, and then I probably did it 5 times.
Okay.
That's
Yeah, I mean, it's a good option. Basically, it's like replacing the cartilage cushion. Yeah. Yeah. So it's definitely something to consider before like taking the steps to considering joint replacement.
I did, first few times, and actually most this time, so that kind of sounds good. So they're done them all.
Yeah. Yeah.
No, not much. Watch yourself. I didn't guess that. I didn't want to be, no, not doing this more than.
Any other questions?
I have a question between, the, rheumatoid and the osteoarthritis. Is rheumatoid more disfiguring than osteo?
Yeah. Yeah. So rheumatoid arthritis, if left untreated, can potentially cause deformities to the joint because of all that inflammation in the joint space. So typically that one, we consider the medications, the ones that we recommend that are beyond this presentation are considered to be disease modifying drugs because they'll prevent progression and further damage to the joint. So yeah, if you've seen like that more typical picture of patients with like deformed fingers, that can be due to uncontrolled rheumatoid arthritis.
So had they started medication sooner, would then that not have gotten to that?
Potentially, yeah. Mhm. Yeah, and for that, we're using medications that are more targeted at the immune system because that's what's causing the pain and inflammation is the overactive immune system attacking the joints. So if we're able to get on a medication that calms down the immune system, it can prevent the damage and that inflammation in the joints. Yep. Anything else? Great.
Thank you so much.
Yeah, absolutely.
No, no, unfortunately not. Talking about going. Well, people always go, I know, I did go. But it was, a family all got together. And it was me up with my, trying to give everything. We just went down.